Thank you all so much for being here. My name is Ushma Patel, Director for Special Projects and Educational Programs at IPFCC. Um, Happy New Year. Today is our first session of 2022, and I'm so glad you could come. Welcome to Preserving the Essence of Family Presence During the Current Phase of the Pandemic, Supportive Strategies for Patients, Families, and Staff. I'm joined by several of my colleagues today, Bev Johnson, President and CEO, and Deborah Dawkin, Coordinator of Patient and Family Partnerships. The two of them will be facilitating today's discussion. Natasha Reed, Registration and Database Manager, is also online, and she's our tech expert. So if you have any issues with Zoom or anything, please feel free to reach out to her via chat. For those of you who have are just joining us, we do have a quick poll on the screen. So please go ahead and fill out that poll so that we can see who all is in the room. As of right now, about 28 of 40 of you who have voted so far. So I think there's still a few more votes that we'd need, and then we'll go ahead and close it. So far, we have a good mix of, coordinators that are responsible for implementing PFCC, patient and resident or family advisors, also some patient experience and patient relations personnel. Always happy to see as well administrative and clinical leaders, quality improvement staff. So wonderful to have so many voices at the table today. Thank you, Natasha, for sharing the poll results. So as you can see, the majority of you are coordinators. Nice to see a patient and family advisor voice as well. And let's see who else. We have some physicians and nurses. And for those of you who don't see your title here, please feel free to chat that in. All right, next slide, please. Wonderful. So if you haven't already done so, please chat in your name, your organization and setting. So, whether you're coming from the adult side or pediatrics, hospital or primary care, as well as your location. Today's conversation won't be a formal presentation. I know many of you have joined our informal conversations in the past, so you'll know that it's really more of a discussion on what organizations are doing in the field and in the environment today. And we all are trying to just learn from each other in this collaborative manner. The resources and recording from today's conversation will be loaded on PFCC Connect. So feel free to head there if you need to see anything after our conversation is done. And we encourage everyone to speak up and join the discussion either during our verbal discussion, but also please utilize the chat to talk to each other, share thoughts, and or any concerns that you have, as well as your own resources. Next slide. So now let's jump into the conversation for today, preserving the essence of family presence during the current phase of the pandemic, supportive strategies for patients, families, and staff. So I will turn it over to my colleagues. First, Bev Johnson, to get us started.
Thank you so much, Ushma. I am just delighted that so many people could join us from across North America today for this conversation. We know it is a very challenging time for all of you, and I'm hoping that in today's discussion, we can identify really emerging best practices for how to preserve the essence of family presence. And as we think about that, always in our mind, and I hope for you all, what are the key strategies that will be supportive for patients and families, but also for staff and clinicians? this is a very unusual time in healthcare, and I think we need to work in a collaborative manner to figure out what are the next steps in this horrific pandemic. Next, please. As we begin this year, after almost 2 years of this horrific pandemic, the reality of what I think most of you are experiencing in your organizations are extremely high rates of Omicron and other COVID-related infections. The hospitalizations are at almost an all-time high. If you compare it to what we were a little over a year ago, they're extremely high now. Perhaps not quite as many people in the ICU, but it comes at a really challenging time with extreme nursing shortages and shortages among other staff and other departments as well. We've talked to people who are seeing, there are many less respiratory therapists available. There have been many resignations among environmental services, and it's creating a lot of pressure on nurses to manage and to assure quality of care, as well as other staff working today. I think we also see that the majority of inpatients that are hospitalized today are unvaccinated. And for staff who've been on the front lines, risking their lives for almost 2 years, emotionally, this is hard because of the choices that some people have had. So that complicates the issues and the experience for everyone right now. And I'm sure you all would agree that everyone is exhausted, really somewhat demoralized. And in lots of conversations with staff, I'm also hearing that in this phase of the pandemic, they no longer feel like they're even appreciated, that there was, at the beginning of the pandemic, there was this recognition. But now, as it's gone on and on and on, people are feeling appreciated, the lack of appreciation. But I think there are some encouraging signs. And I think more than ever today, those core concepts of patient and family-centered care can help in the healing and help in really almost rebuilding our healthcare systems. So just to ground us, respect and dignity, information sharing, participation, and collaboration. Those mutually respectful partnerships are key to going forward. So Deborah's going to pick up and talk a little bit about the key issues related to partnership. Deborah?
Thanks, Bev. Next slide, please.
Good. Go.
So Bev just introduced the core concepts, and in thinking about this informal conversation and what we were hoping would happen in your discussions with one another today, we just outlined what we thought some of the key issues are. Of course, policy changes that have occurred recently, but also what is the communication about those changes in family presence policies, and especially is a term like essential care partner used instead of visitor. Preparation and support for family members and care partners. And then the involvement of PFACs and other PFAs in both developing any changes in policy, but also communicating about them. Addressing some of the challenging situations that Bev alluded to. And finally, Bev also talked about the need for appreciation and support for staff. Next slide, please. So we very decidedly, in the title for this informal conversation, talked about the essence of family presence. We understand that there are changes that will be made as the pandemic changes, but what is the essence of family presence? And as you also see in this slide, we think it revolves around the care partner, the essential care partner. So first of all, that every patient has one designated, that there is an understanding that care partners are integral to quality, safety, and the experience of care, that care partners provide invaluable information as well as comfort and emotional support, and finally, that these care partners are considered members of the healthcare team. So what we want to do right now is launch our second poll and find out from you what, how many of you have made changes recently in your family presence policies. So we'll just have a few moments of silence while you respond to the poll, and then Natasha will show us the results. Thank you, Natasha. The poll results are what we expected, that a very, very large number, the preponderance of your organizations have made some changes with the emergence of Omicron. So Bev, do you want to start now in getting our participants to converse?
Yes, so let's go to this question. And I think, one, it's important to recognize if the majority of organizations on the call today that changes are being made to deal with the Omicron surge, who is really involved in shaping these revisions? And sort of a sub question there is, our PFCC leaders, PFACs, and patient and family advisors involved? So we've been interested in some of the work at Anne Arundel and Luminous Health System. Camilla, are you still on the call? Could you describe a little bit the process there?
Absolutely, thank you. So we, oh gosh, it's been about a year now, I think. Well, a little less than a year. No, it was actually last November, I believe. Can't recall the exact date that we started, but we convened a group, a very, very, I'm proud to say, well-rounded group of individuals to look at what we could do with visitation, because we knew that having no care partners in-house was not the right way to go. So we wanted to figure out how we were going to restart visitation, but we wanted to get the right people at the table to have that discussion. So our group includes members of our Patient Family Advisory Council. It includes our experts in infection prevention. It includes our experts on our ethics, from our ethics committee, staff nurses, nurse leadership, and then we also have community partners as well, which include members of the clergy from different religious groups in our community, members of the Hispanic population, members of the local government, And I believe those are the main folks in our, yes, and the title is Community Partners and the and Family Presence Team. Thank you, Deborah. So it's a very well-rounded group that has these discussions to make decisions on what we do about visitation. We've had 9 meetings so far, and we've made several changes over this time that we've met, and all based on the science and also based on what makes the most sense in terms of recognizing the value that care partners bring to our patients and our care teams. And so we balance those two. What does the science say versus what makes the most sense in providing the highest quality care that we can to our patients?
Thank you, Camilla, for sharing that experience. And we have followed that because last January and February, a team of us from IPFC was working on a document to help guide the decision-making for changing family presence policies and to really developing a process that blended those core concepts of PFCC with ethical principles. So we would get a better balance between the benefits and harms caused by change in policy. So I hope somebody can put a link to that. It's free, it's on our website. And Anne Arundel was one of the first, they actually began using that wheel and that process early on to put together that community team. And I think that Lisa Allen from Hopkins, I think you're now able to join us. She was going to be at another meeting, but I think you're on. I think Hopkins has done some really interesting work as well, and in broadly involving people in this decision.
Yeah, hi Bev, I am on.
Oh, great.
Our other meeting ended early, which is great. Yeah, I think it's, this has been such a challenge in trying to balance. We had started early on of creating different levels of threat in the community. So, and that was really based on the number of cases per 100,000 individuals, both at the state level and at the local level. And, I think when we first started and things went up, we were very reactive. We closed things down, and we have infection control on it. Myself as the Chief Patient Experience Officer, our Senior VP for Quality. We have our emergency management individual, our CNO for the system, as well as our CMO for the system. And we've had some pretty intense talks over the past couple of years in trying to balance risk of infection versus really the need for care partners. So the first thing we did with our PFACs is we redefined visitor, and we don't talk about visitors anymore. I think gone are the days of the slow cooker in the family waiting lounge where everybody's picnicking. It's really redefining it, and maybe we'll get there eventually, but it's really redefining is who do you need by your side that provides emotional support, provides communication support, that can be there to help make you feel more comfortable or understand what the physician has said. So as we've gone through this, we have a very complex grid. And as we started seeing Omicron come back in, we said we can't, definitely went over what we call our purple or our highest level risk. And I said, we can't go back to no care partners. We just can't do that. We get the issue of infection. The biggest challenge has been getting care partners to wear masks in the room. And I think that's where we end up getting the pushback. So we are at the point now where we do allow one care partner. We're not as good as Anne Arundel, where we allow it for COVID patients. I wish we did. We do have visiting hours, 8 a.m. till 9 p.m., where people can come in. Of course, we have disability and end of life exceptions. Pediatrics is still 2 parents, 24/7. But we have created it where if you're going to stay overnight, it either has to be because of an exception, or now the care team really believes, and especially in this time of limited staffing, believes that it is in the best interest of the patient that the care partner stay overnight. And the care partner is willing to, and willing to keep that mask on. And we know it's hard to sleep with a mask on, but that's been the biggest pushback. But we've tried to be very methodical about cut points of when we go to higher levels. But I'll tell you, there has been some pretty heated conversations about this. And at one point early on, even our patient family advisory councils wrote a letter along with our ethics team and a few other groups that said, we can't not allow a care partner in. They are so essential, and it is causing distress not only among our patients, the families, but also the staff. So I think we won't go back to that. But it's really been a process, and really having the voice of our PFACs, and we have 17 throughout our system, have been really powerful and important. And they are very grateful that we can have one person come in at this point, because people may or may not know, but Maryland was one of the early hit states, and never before saw numbers in the 250s, close to 300 per 100,000. We were, in the summer, we were down to 6 or 5. So we really got slammed.
Lisa,
And happy to take any questions.
Lisa, that's so helpful. And you have a wonderful article in the Patient Experience Journal that was written earlier in the pandemic, but I think it's very relevant to what you were sharing. So we'll put that in the chat as well. I wondered, Jennifer, I think earlier, Jennifer Anderson, I think you're from a critical access hospital. So quite a contrast to Johns Hopkins. It's your hospital incident command group that's making decisions. Is it possible to have a dialogue with them? How are you handling this in the rural community?
So can you hear me okay? Yes.
Yeah.
Okay. So I represent 2 critical access hospitals. We're part of a little bit larger, a small health system. It's one level 1 trauma center, tertiary center, and then we have 4 community hospitals and a long-term care facility that are all part in a tri-county area in Michigan and in the middle of Michigan. And our hospitals took the approach early in the pandemic to restrict patients. And it was this incident command that was set up for our entire health system, which involved local leadership, nursing leadership on the incident command, which involved all the specialties that I think Lisa was talking about, with infection prevention, emergency management, nursing, physicians, quality. It was a whole employee health. There was human resources. There's a lot of people involved in that incident command. The local hospitals early in the pandemic, we restricted visitors all from the ED, from inpatient, and quickly realized that that was not working in our rural communities. We knew the value of the family members in helping, especially when we have patients that are elderly. A lot of our critical access hospitals, we have age-friendly 65 and older patients, and just knowing their health background, as well as having the care partner there that helps with assisting with the patient. So reminding them, don't get out of bed unless your nurse comes, until your team comes, to prevent falls and things like that. So
Yeah.
we, well, the incident command direction was to restrict visitors. We started adopting it and realized that we needed to have the care partners with the patients. Now, most recently, the incident command reevaluated our visitor policies again, and making sure that our patients we have one care partner right now that's identified for the day. And then that person needs to coordinate. The expectation is that person would coordinate with the rest of the family to figure out when that we're not having coming and going of people throughout our facility. The thing I would say in Michigan right now is that our little hospitals, which normally have a census of maybe 6 or 7 patients, We're licensed for 22 to 25 beds, and we are at capacity with that 22 to 25 beds. And so limiting the number of people that are coming in and out of the hospital, but honoring the family is important. And then the emergency department, wish we would have had, we had limited the number of patients, care partners that could come into the emergency department, and that was abandoned early on, and we continue to allow one person to go with a patient in the emergency department, but doing what we can to limit the number of people that are coming and going. They have to all have now, they all have to have hospital quality
Masks.
masks and PPE. They can't come in with the cloth masks anymore. We're screening everyone that comes into our facility, so they have to go through the screening process. We haven't required them to be specific vaccinated, but it's and then each department, on a case by case basis. I mean, the staff is when you started this and talked about where the staff, I was like, oh yeah, that's exactly how the staff feels. They're just feel defeated and deflated and exhausted, and they want to do what's right for each patient, and they really dig deep to be able to do that. They've come up with some really creative ways to communicate with family members utilizing iPads and different kinds of support from the family.
And that's great. And it's wonderful to hear, what's important in the rural communities. What I heard from another large academic medical center from the Midwest was, early on, at first nurses were saying, we have to lock down, we can't have anyone else here. And I think over time, even nurses and other clinicians have learned that families bring important vital information, and that they're supportive to the patient and they're supportive to staff. So in this Wisconsin physician shared with me that nurses now see, because of the short staffing, that families, care partners, are their eyes and ears. They can't be with the patients because they're so short staffed as much. So they're relying more on them, and that they're sort of, when a care partner is there, they're saying to them, you're the communicator of the day. And
Yeah.
so that again makes less work for other nurses.
Yeah, Bev, it's Lisa. I would say, Jennifer, talking about that reminded me, we had in lower levels of COVID allowed more people to rotate through. 4 care partners a day could come through. We're at 1 per 7 days. And really, in looking at the data and saying most patients don't stay more than 7 days. So you now have one person who becomes the consistent messenger, who learns the rules. And so I think that comforted people. They know they have a care partner there to help support the staff, and it's the same person. And so I think it got rid of some of the fear. So for those places that maybe have locked down, trying that approach to say, let's try just one person. It seems to have gone better.
That's interesting. So we might hear how other people have handled that issue. Why don't I turn this over to Deborah, and you explore a little more about how these guidelines and policies are communicated?
Right. Thanks, Bev. So we said earlier that we wanted you all to share not just how policies were developed and changed, but how were they communicated, and how were PFACs and PFAs involved in that process. I know Caroline DeLongchamp is on from the Medical University of South Carolina. And Caroline, could you quickly share about your very recent example of how the PFAC got involved in the communication about the revisions.
Sure. Thanks for having me, Deb. Can you hear me?
Mhm.
Okay. Yeah, I think we had we had the benefit of having some muscle memory. Our patient and family advisors were or have been in the past involved in writing letters regarding family presence and visitation due to what some of you may recognize as, we have weather events a lot in South Carolina. So years and years ago, our PFAC wrote a letter communicating family presence and visitation during a storm event. And so fast forward a few years later with COVID in 2020, right as MUSC was moving into emergency operations, so did our PFAC. And they were at the helm of writing our initial family presence and visitation policy a couple of years ago. We went through about 29 different iterations of that policy over the last 2 years and finally graduated because we were working to make it better and better as things would ebb and flow with the pandemic, but recently graduated to a tiered system. So we have normal operations, modified operations, and emergency operations. We just moved into emergency operations at the end of December. And what we heard from our PFAC is that, yes, we're happy to help write the letter, but more importantly is how that letter and the information in the letter is communicated, not just to patients and families, but the community. So making sure from a broader perspective that what's happening here in our hospitals communicated via newspaper, television, but specifically with regard to the letter that we wrote, it is handed out in the welcome packet by the admitting nurse. It is given in the emergency department upon admission. When a patient is transferred, they give the letter, and then it's also distributed at our front desk. Does that answer your question, Deb?
Does, yes. Thanks very much, Caroline, for always being willing to share. I want to check, is Darcel Jackson on?
Yes, I'm here.
Oh, hi, Darcel. So
Hello.
can you quickly share about how you use the PFAC with messaging about policy changes through the Get Well network in patient rooms?
Yeah, absolutely. So I'm with Children's National in Washington, D.C. And one of the things that we did is our hospital-wide patient and family advisory council was included from the very beginning and really partner to say, to not only help establish what, if any, changes was going to be made to the policy, but how we communicated that. And so what we did is we created a video that was specifically from our parent co-chairs of the council that was put on our website, but also our Get Well network that would be able to be viewed by all of our inpatient families, but as well as some other families that were, say, in our ED, that really shared not only our policy, but just really from parent to parent, patient to patient, is we understanding this is a really difficult time and we're all in this together, and really helping families identify with some of the restrictions, because at the time, our restrictions were one parent or guardian to be present at the bedside. Is how can you utilize technology to incorporate the other care partners. And so really introducing the concept of telemedicine visits, utilizing iPads that are in the inpatient rooms, et cetera, to really make sure that although that there could not be the family presence that people were used to, here are other alternatives, but that also, I think, really setting the stage that this decision, although difficult, was made in conjunction with patients and families with the information that we had at the time. So the video is still there, still viewable, and can be changed as we need to change as our policy and what's happening changes in our area.
Okay, thanks very much, Darcel. I just checked the chat. Right at the moment, I don't see any other examples in the chat, but does anyone else have an example about how PFACs or PFAs or specifically involved in the messaging about any changes in policy. It might be the website, it might be social media, any other ways. And if you don't,
Deborah, looks like Bonnie has raised her hand.
okay,
And Bonnie brings a Canadian perspective, so that from Thunder Bay, so
great.
that would be helpful.
Hi,
Please,
can you hear me
floor.
okay?
Yep, we can hear you.
So we learned a lot of really hard lessons when we first began looking at the visitor restrictions when COVID first came. And understandably, everybody panicked and was not aware of what was happening with COVID and kind of went to a reactionary way of dealing with our patients and their essential care partners and care partners, and ended up being locked down. And there were a few people that had really detrimental stories that they shared with us. And so from that, we learned that we truly need to involve our patients and our families and those that had those terrible stories in developing what the guidelines were going to look like going forward through the different levels of our organization, because our organization has various levels within the organization, and what the guidance document that we developed in collaboration with our patients and families have different response levels at our organization, and how we will organize ensuring we have essential care partner and care partner presence. So we have prevent, protect, restrict, control, lockdown, and what happens in an outbreak. The surprising thing about that is, as we went along, initially there were some restrictions when we started getting into restrict, and they were feeling that the care partners needed to be protected, but we put a process in place where we had care partner liaisons, and it was a brand new role that we made so that they could support the essential care partners, so we could ensure that they had the patients had the tools they need to understand what resources they had available to them. Like, we could facilitate virtual visitations. We had extra iPads, and we went to the patients to help facilitate that. Also, we were able to meet with our essential care partners when they came in to ensure that they understood how to properly don and doff their PPEs, how to properly hand wash, to ensure that we were covering those infection control practices that we needed to make sure that our patients, our staff, and our essential care partners were kept safe. So we put those processes in place, and I can tell you, even going to control, and now we have just gone into lockdown, we are still providing access to our essential care partners, because, and this is the term that they used in Canada, they qualified what the care partners were, right? So essential care partners are ones that absolutely need to be there. And if the patient says they need to be there, they need to be there. And so it's the patient, not us, that determines that criteria, right? And so we learned a lot early on, and it really helped us as we moved through our levels from being, just in a prevent or a protect phase, all the way up to our lockdown phase, which we have just gone into as of yesterday. So it was a very useful tool, and if anybody is interested in seeing what our document looks like, I'm willing to send it to Bev or share it with this presentation as well.
Thanks so much, Bonnie. And Bev, I'm going to turn it over to you now, because Bonnie has so transitioned us into a real sharing of ideas about care partners and their role and their importance.
Terrific. And I can see some other comments in the chat from people in Canada. We consider the healthcare excellence in Canada a wonderful partner and leader in this work. Jesse, are you still on? It would be great if you could describe a little bit about the essential care partner across Canada, some of the materials you've developed to help in bringing about substantive change. And we can move on to the next slide, Natasha. Thanks. Jesse, are you there? And if not, I will, just as a follow-up, if somebody could check to see if Jessie may be having trouble or is still on mute. I saw her earlier. Let's.
Bev, this is Ushma. I actually don't see her online, so perhaps she had to go or drop off.
You want to try to email or text her, you or Natasha, and because, but otherwise we will
Sure.
put some of the important links in the chat from Healthcare Excellence Canada, because they really have developed excellent programs, a change package. They have an excellent evidence brief. And I know that Misty, you've raised a question about, making sure that nurses are on board, and the evidence brief might be helpful to you. There was a study reported out a few months ago that nurses, contrary to what many leaders expected, nurses were saying not having families present was really adding a greater burden to nurses, not only for sort of practical day-to-day work in terms of helping the patient, but that to be the primary emotional support on the front lines to patients was particularly physically and emotionally draining. So I think that those resources, even though they're from Canada, could be very useful to you. I think the story I shared from Wisconsin about nurses finding that they're helpful, I think part of it is preparing essential care partners for their role. And that's really helpful. And I think Darcel at Children's Here, set the stage for that kind of discussion. Jackie, are you able to talk about some of the work at Ottawa and engaging the PFAC? Do you talk about essential care partners on your website?
Yeah, we do. We do in Ottawa. It was a bit of a slog getting there. We had quite a bit of pushback from not so much from staff, some staff, yes. We had kind of a mix of staff who didn't agree that they were essential, and other staff who really wanted it, like you're saying, those nurses, I forget where, who really valued, because we're short-staffed, and families provide this time with loved ones that helps out when you don't have nurses and other staff available. So that was really good. We engaged our we have actually two separate councils, one for clients and one for families. We heavily engaged, obviously, the family one, and had also consultation with the client one council. The family council was very engaged. One woman did amazing amounts of research online and provided us with all kinds of documents. We use the documents that you've put up there from Excellence Canada. They're fabulous. We have a great partner here, the Ottawa Hospital. So we're a mental health hospital, and our partners in acute care already had all the documents, and we said, can we borrow them or whatever? And they said, yes, please don't reinvent the wheel. They had great videos to train essential care partners. They can just click on, get on, see how you mask, see how you do all kinds of things. And they also had a document defining the role, which we didn't adjust a whole lot, but a document that was ready to go. And we provided it to, and our communications kind of branded it for our hospital, I guess you could say. And it's been great. We've had no pushback. And this time around with the we have to lock down, we had to go put more restrictions in again because of the increase in COVID with Omicron. And there was no question that ECPs were not going to be closed out again. So it really had a big impact. The one thing I would say that really helped was, I call it managing up in my role in client and family relations, and saying to our senior team, I've given you all the materials. You've heard from your family council. We're engaged all together. We're co-designing this. The policy's there, all the materials are there. You have to make a decision and put this out across the hospital. Like it can no longer just be client and family relations peddling down here. You have to own this. And they did it. And all of a sudden it was like new policy, here you go. And we've had no kickback, nothing. It just got implemented and it's working well. I have no complaints, nothing. So it's.
Jackie, I mean, so many important lessons to learn from that. I hope all of you are listening about what they've done for mental health, because again, in observing and looking at websites, often there is much less access to a care partner for mental health. So thank you for sharing that and sharing how the broader leadership needs to take ownership and be communicating. I think Darcel is reflecting also on what frontline staff are having trouble with is dealing with the issue. I think, Lisa, you may have mentioned it early on in our conversation about the resistance to wear masks. And I think we need training and support how to de-escalate that, and how it has to be communicated to everyone that they must be worn. But I'm sure for the people on the front lines, this is really difficult. And nice to see that your PFAC at Children's National has helped develop some scripting that can be used with families. Let's see. Jesse's not on yet, I don't think. Is that right?
No.
All righty, let's move on to the next question. Well, let's go on to the next question. We'll cover some of these other issues. Others of you may have a comment, but Deborah, you want to talk about it? Because I think
thanks, Bev. And I did want to comment on one other thing that Jackie mentioned that really seemed to help their process, which was when she said they used documents and materials that were already developed. In this case, probably many of them were from Healthcare Excellence Canada, but in a time of crisis, being able to do what we're doing today, which is share information and then not to spend time reinventing the wheel and that's one of the reasons why there are all these resources provided in the chat, and Bev will talk about another way to access resources a little later. So Jackie started talking about essential care partners and some ways that their role is highlighted as being supportive to staff, but also how they might be prepared to really be most effective in that role. And we'd love to hear from any of you who have examples to share. But first, we're going to ask Christy Thibodeau from Caring Bridges to talk about a recent initiative that they had with UMass Medical Center right at the time of the pandemic, so that Caring Bridges could be used as a resource to really enhance the role of care partners. Christy, are you on?
I am. Thank you, Deborah. So thank you for allowing me to participate in this conversation. So I'm not going to take up too much time, but Caring Bridge is, you all may be familiar, we are a communications platform for patients and their family caregivers. We have been around for 25 years, and our primary use case has really been around a new diagnosis and allowing that patient and family caregiver to tell their story in a safe and protected space to their loving community. And we have had long support through social work and child life and chaplaincy and nursing. However, during the pandemic, we've seen kind of a more broader acceptance of CaringBridge as a tool or an alternative kind of family presence strategy that hospitals have been using. And so UMass Memorial Medical Center reached out because one of their leads within patient experience was very familiar on a personal case using CaringBridge. Their PFAC validated their own broader use and trust of our resource. And so patient experience, actually, they quickly leveraged CaringBridge as a resource that they were telling those patients that were at intake and their family caregivers, please start a CaringBridge site, identify your designated support person who will be the one that will be journaling and communicating. Please do not have loved ones call the medical center to ask questions of the patients. Use CaringBridge to do all of that communicating. And so they were doing things like that. They downloaded CaringBridge, our app, onto patient bedside devices so that that patient, if they were able to still feel that family presence through a private and secure site where they could communicate and share pictures and just provide updates and read loving messages while they were isolated. And so I believe that Deborah will also share a link that we did a co-webinar with UMass on the Massachusetts Hospital Association. So thank you.
Thank you, Christy. And yes, we will be sharing the link. And I'm reminded, Christy, when you were talking about how CaringBridge was used to really enhance the role of the care partner, I'm reminded of Bev's earlier comment about the communicator of the day and how you were really able to do that. Does anyone else have an example they want to share of ways that care partners were supported and prepared in any new ways for their role during the pandemic, specifically this new surge of the pandemic?
Deborah, but you might want to call on Bonnie Nicholas again.
Okay.
I'm
sorry, I missed that in the chat.
No, there's so many wonderful pearls in the chat. I think we want to hear more about, we can redeploy staff, and it sounds like also they've created some new positions to support care partner liaisons. And I think we also ought to address, let's hear from Bonnie and Misty's point about nurses saying, I liked it before when there weren't that many people here, and how you might handle that. So maybe Bonnie and then Misty.
Hi, can you hear me okay?
Yes.
So Bev, there were some nurses and other healthcare providers that said the exact same thing here. They found, when we were in the tightest lockdown in the early days, that they were able to get their work done. There weren't families around asking questions and things like that. So that was a little bit harder going back to having our essential care partners coming on site, but with the role of the essential care partners coming in and the role of the care partner liaison, which was a role that we identified because we had a lot of services already set in place when the first wave of the pandemic hit. We had televisitation. It was very well developed. And it was available to any of the patients that were in the hospital, and they could access it as they wanted. But the problem was we had a lot of really great practices that were going on in our organization that our patients didn't know about. And maybe some of the staff didn't know about. And so we created this position of a care partner liaison, and really what their role was to bridge any communication gaps between the patient, the healthcare team, and their essential care partner. So some of the earliest barriers, I guess, at the beginning were even just about communication devices. Some people may have had a cell phone, but they didn't have chargers. And so the care partner liaison would facilitate them getting a charger, would facilitate a virtual visitation through an iPad. We went and bought a bunch of iPads so that we would have them available to patients that, maybe their essential care partner didn't want to come in to the hospital at the time because of the risk. They may have other issues. They may be living in a northern community. So whatever their reason is, we would bridge that gap between the patient and their essential care partner and the healthcare team. Some of them wanted to speak with the physician face to face. So we were able to have a care partner liaison that was dedicated to the role of informing the patients what the resources were available to them, a number that they could call so that they could have any questions answered that they may have. And also, it wasn't that they were just supporting the patients and the essential care partners. They were a critical collaborator with the healthcare team. Many of the leaders resource the care partner liaison so that they knew what the most update guidelines were, or supporting our essential care partners coming into the organization. So we hired 4.2 FTE equivalents of care partner liaisons. And so we have somebody that works in the emergency department 12 hours a day, 7 days a week, and somebody that covers the inpatient units as well. We focused on the medical.
Bonnie, I'm going to have to ask you to pause. This is wonderful information. I'm going to ask you to save it and share with us in a document that we will share with everyone about more how you're creating these liaison roles. I think that would be so helpful to us.
Perfect.
I know everyone is so swamped right now, and I want to make sure that we address all the issues. One other one that we haven't had time to talk about, that some people who are in non-patient care areas are being asked, some in administration and broader, to volunteer for 2 to 4 hour blocks of time to help frontline staff. So maybe that helps. Misty, your comment about nurses not feeling like they've been abandoned to be the front lines and they're all alone, but to think about that. And then Lisa Allen in the chat also talked about anyone training care partners to be sitters or observers. There is an article, I think it's mainly about long-term care, but it's in Health Affairs, and we will send that article and a summary of that study about people hiring families to help in this situation, training them and to be somewhat like you're talking about liaisons. So we will be sending you further information. This has just been such a dynamic conversation, and we could have probably spent the whole afternoon learning from all of you. Can I have the next slide, please? So as follow-up to the discussion today, we really see that the changes in family presence policies and guidelines is really at a critical moment. And we want to just surface and disseminate as many of the emerging best practices. We're not saying this is the only way, but this seems to address some of these issues. So we are organizing, we're going to draw from what you all have shared. So please continue to send us information, and we can include this. This is sort of like a growing working guidance document, and we're going to try to have it out to you next week. So please, thank you so much. I'm going to turn it over to Ushma with the next slide to wrap it up. And again, thank you. Stay safe to all of you.
Thank you, Bev, so much, and to all of you for such a rich discussion today. I know we're short on time, so I'm just going to breeze through this, but I encourage you to check out our website, specifically under PFCC best practices. You can find a section on COVID-19 that includes several different resources, But first, the top one there that we've put an arrow on, the family presence document during a pandemic. So definitely check that out. Next slide, please. So for next steps, I want to assure you that we will be posting a recording of today's conversation, including the chat with all the resources and the slides on PFCC Connect. We will continue the discussion. As Bev mentioned, we'll be sending that emerging best practices communication to all of you. And we encourage you all to not only complete today's evaluation, but again, send us any links or examples that we can include. And then in PFCC Connect, please start a new conversation, a new discussion question, and engage with each other even further. Next slide. Here's where the resources will be posted for those that are new to informal conversations. We'll have a specific folder for today's session, and then you'll be able to find all the documents there. Next slide. Great, and then mark your calendars for IPFCC's next free webinar on January 27th at 1:30 p.m. Eastern for creating authentic partnerships with urban underserved communities in research during COVID-19. You'll hear from one of our latest projects that we had funding support from PCORI, and we partnered with Smart from the Start. We'll be sharing some resources on information and strategies to address and identify barriers in engaging communities in research during COVID-19. So please register for that. I see that Marie has already posted the link there for you. And next slide, please. Great. So that is, all the time that we have today. I really wish we had more time. This is such a rich and engaging discussion. Thank you so much for participating, and please fill out the survey. We want to hear from you. We want to know, what the next topic or idea you'd like to discuss in March. So please, fill out the survey. And if you can't get to that, you can also send me any ideas for future conversations, as well as tools or resources at the email address right there on the screen. So thank you so much for joining, and we will see you all soon.
Thank
Take
you,
care.
everyone.
Be safe.
Bye.
Bye-bye.